So jumping right in, lung nodules come in many shapes and sizes. What do we do with all of these? Well, some are clearly benign. Others we find out they're benign after tissue sampling. Others are very suspicious for malignancy. How are we supposed to distinguish between these nodules? That's our goal as the radiologist, and that's what I'll be talking about for the next 45 minutes or so. So what are our goals as radiologists? Well, predicting the risk of pulmonary nodules and suggesting histology when we can based on the imaging appearance. Recommending the next best step in management to our colleagues in pulmonary, hem-onc, and other interventional specialties. And then providing relevant details to help our surgeons and oncology colleagues manage the patient most appropriately in terms of whether this patient is a surgical candidate or would be more appropriate for chemoradiation therapy. So our goal in order to address these questions is to answer 4 key questions in patients with suspected lung cancer. Could this be cancer? What type of cancer? What is the next best step? And then, is this resectable? Kind of getting at that final point on the last slide. So could this be cancer? Imaging predictors of malignancy risk is where we will start off this talk. Size is a great predictor of malignancy risk. Likelihood of malignancy going from less than 1% in small nodules, data we have from the National Lung Cancer Screening Trial, to an intermediate risk of malignancy, 10 to 30% in these intermediate sized nodules. And then for very large masses that are persistent, the malignancy risk can obviously increase quite substantially, 60, 80%, depending on the context and what's going on with the patient. So size predicts malignancy risk. Nodule composition is also very important in determining whether or not a nodule is neoplastic. So when we're thinking about all solid nodules in patients of all sizes that are persistent, sticking around for more than 3 months, versus all ground glass nodules that are sticking around for more than 3 months. During my training, I was surprised to see that the risk of a neoplasm or malignancy is actually higher with these ground glass nodules. Persistent ground glass nodules are very suspicious for pulmonary adenocarcinoma, whereas the malignancy risk or neoplastic risk in solid nodules is lower. Some of these are granulomas or post-infectious. The border of the nodule is also a major predictor for malignancy risk. Spiculated nodules are very suspicious for primary lung cancer, although some granulomatous infections can also give you this appearance. And round nodules is more of a mixed bag. We have 2 separate nodules here that are quite circumscribed and round. One of these is a hamartoma and the other is metastatic renal cell carcinoma. So the border is helpful in predicting primary lung cancer. Metastases and benign nodules can be more circumscribed. And then growth rate is another important predictor for malignancy risk. This is a patient with 2 sequential lung cancer screening exams. Intermediate growth is the one that's the most concerning for malignancy, and that corresponds to a volume doubling time of 3 months to about a year's duration. And there's some calculators online that you can use or that your other colleagues, maybe clinical colleagues like in pulmonary, may use. And we have a multidisciplinary conference at our Veterans Hospital where they will have calculated the volume doubling time for these suspicious nodules when we discuss them in terms of multidisciplinary discussion for the next best steps. So there are 2 nodules with a 6-month follow-up time. That timeline, very suspicious for a small growing lung cancer. So now that we've talked about the risk factors, let's talk about the typical appearances of lung cancer with a focus on pulmonary adenocarcinoma given its varied imaging appearances. We'll start off with squamous cell. This is going to have a cavitary morphology, commonly with both primary and metastatic squamous cell carcinoma in patients with heavy smoking history. We have this low attenuation, masses with regions of cavitation. One of these is a primary and one metastatic squamous cell carcinoma. And the risk factors, as I just alluded to, smoking and head and neck cancer patients also with a heavy smoking history. Squamous cell carcinoma tends to look differently. This is often a large central mass with lymphadenopathy, and many patients have metastases at the time of presentation. So small cell is an aggressive tumor, often large with metastatic disease by the time they're coming to our attention. I want to focus now on pulmonary adenocarcinoma. As I mentioned, this is the most common lung cancer that we're seeing and is usually a peripheral nodule, lesion, or mass as opposed to central, but can be anywhere. And there are many appearances, as I just referred to, solid nodules, ground glass nodules, mixed solid and ground glass, and then this pseudocavitation appearance that I'll show in upcoming slides. And smokers and non-smokers get pulmonary adenocarcinoma. We also see this in younger patients in their 20s, 30s, 40s. So many different types of patients can have pulmonary adenocarcinoma. The pulmonary adenocarcinoma spectrum is something that we think about and discuss, and that's that spectrum of non-invasive manifestations of pulmonary adenocarcinoma all the way up to frankly invasive. And fortunately, those differences in histology also have a predictable imaging appearance on CT. So we can use that to help predict the histology over serial exams or when we see a patient with a suspected adenocarcinoma. I'll go through this in a bit more detail on the upcoming slides, but here's a classic non-invasive or adenocarcinoma in situ, a ground glass nodule in 2013. And then as we follow this over time, notice that the overall density is increasing and a small solid component is beginning to develop centrally. And by the time we get to 2017, this nodule is almost entirely solid. That's the evolution of a non-invasive to an invasive adenocarcinoma. And we have all the different stages represented here: adenocarcinoma in situ, minimally invasive adenocarcinoma, and then finally invasive adenocarcinoma. So let's focus in on this RAD path correlation for adenocarcinoma. In JTI 2011, there's this description of the RAD path correlation histological findings and then the corresponding CT appearance. So starting off with atypical adenomatous hyperplasia, these are atypical cells along the lining of the alveolar spaces. The overall size of this is quite small, 5 millimeters and smaller, no solid component. And what we're seeing here is lipidic growth of abnormal cells. So what is lipidic? Well, I have two histologic slides here: normal alveolar architecture, and then a patient with lipidic growth of pulmonary adenocarcinoma. That's tumor cells growing along the alveolar lining. So you see that these alveolar septa are thickened and infiltrated by these abnormal cells, but there's no invasion into the actual alveolar spaces themselves. It's all along the walls. That's lipidic growth, not invasion. And so that's what we see in atypical adenomatous hyperplasia. Here is a very small, 5 millimeters or less, ground glass opacity nodule. And this ended up in a surgical specimen, and the corresponding findings is lipidic growth of atypical cells, less than 5 millimeters, very small. Adenocarcinoma in situ looks the same. It's lipidic growth only, but a larger size overall, so less than 3 total centimeters, still no solid component. So here's a nice example of adenocarcinoma in situ on CT. We have a ground glass nodule, no solid component, and the surgical specimen going along with that is a larger area of lipidic growth, noticing that thickened alveolar walls infiltrated by tumor. Once we start thinking about an invasive component, what we're looking for is a solid component developing. So minimally invasive adenocarcinoma is going to be lipidic growth predominantly, plus a small invasive component. So your adenocarcinoma in situ plus a small solid focus, 5 or fewer millimeters. Here are 2 separate patients with minimally invasive adenocarcinoma, ground glass nodules with small solid components. And then finally, invasive adenocarcinoma. This is going to be an adenocarcinoma with a larger invasive component. The overall size can be small or large, but we have a larger solid component that is corresponding to the region that is histologically invasive. And there are a variety of different appearances of this. Solid masses could be an invasive adenocarcinoma, mixed solid and ground glass nodule with a large solid component, and then this pseudocavitary or bubbly lucent appearance, also very common in adenocarcinoma. And so when these are resected, most are a mixture of histologic patterns, acinar, solid, papillary, micropapillary. I'm not an expert in interpreting these path slides, but do bring this up to point out micropapillary specifically. Our histology colleagues have clued us in that the presence of a micropapillary component portends a poorer prognosis, and patients with a micropapillary invasive pulmonary adenocarcinoma are more likely to have lymphatic or pleural metastases, nodal metastases, and so this may be treated differently despite an overall small tumor size, depending on the histologic breakdown. And so if you're in a multidisciplinary setting and having a discussion, that word being mentioned may lead to a more aggressive treatment for those patients. Another subtype of pulmonary adenocarcinoma I want to point out is this lipidic predominant invasive adenocarcinoma. It's an invasive adenocarcinoma that has a large ground glass component. So the overall size, mostly ground glass, but a solid component more than 5 millimeters. And we can see the histologic specimen there with that mostly lipidic growth. And then in the center, little denser, more solid area corresponding to the invasive component. Some larger pure ground glass nodules on CT, so those greater than 1 to 2 centimeters, may also have microscopic invasive components that we just aren't picking up yet on the CT. And so if there's a large pure ground glass nodule, I'll say something like suggestive of at least adenocarcinoma in situ. However, ground glass nodules of this size may have microscopic invasive components. That's like a big ground glass nodule. Another morphologic feature is pseudocavitation. This is seen in adenocarcinoma more than other lung cancer subtypes and has a very high specificity for pulmonary adenocarcinoma. So not always present, but if you see it, very suggestive. And then this topic was also touched on by Travis in the last set of lectures, but sometimes a persistent region of consolidation can also be cancer. Invasive mucinous adenocarcinoma starting out looking like a pneumonia, but the chronicity is key. So over a series of exams from 2009 to 2014, this consolidation and ground glass just keeps increasing and increasing. Antibiotics are not helping. So this is aerogenous spread of pulmonary adenocarcinoma. And the histologic specimen shows this mucin, these mucin-containing glands. So those are the classic appearances of lung cancer. What else is in the differential? What can look like this? What should we consider and try to rule out before we send the patient for treatment for lung cancer? Well, there are 4 patterns of mimics I want to bring up for this talk. Small nodules are going to be discussed by Travis in the next lecture. Other findings we see that mimic lung cancer: ground glass opacities, solid nodules from some other cause, or cavities. So let's take each one of these in turn. Ground glass opacities. We just discussed the fact that persistent ground glass is very suspicious for pulmonary adenocarcinoma, but the persistent part is extremely important. So here's a patient with a nodule that's mixed solid and ground glass, mostly solid, and using the RAD path rules that we just utilized, this is morphologically quite suspicious for an invasive adenocarcinoma. But we need to be very cautious when making that determination with a single time point, especially in a patient that has risk factors for something else like a pneumonia. When we find out a little bit more about this patient, they have AML and were treated with antifungals. 4 months later, this has shrank down, become much smaller. So this is a treated fungal pneumonia rather than a lung cancer. And so short-term follow-up is very important when we're dealing with ground glass or mixed solid and ground glass nodules. In one study, 40 to 70% of those seen on an initial CT resolved on a short interval follow-up. Presumably some type of infection, edema, hemorrhage, any of those things can cause ground glass opacity. So short interval follow-up is important in order to establish persistence of a ground glass or mixed solid and ground glass pulmonary nodule. The next subcategory I want to talk about is solid nodules. There are many mimics of lung cancer which have been discussed in various lectures over the last 2 days. Here's a classic mimic. We have a region of consolidation on the lung window that's been persistent on many prior exams. Suspicious for a lung cancer until we put on our soft tissue windows and we see this is macroscopic fat. Nice classic example of lipoid pneumonia. So chronic consolidation can be from a lung cancer, but can also be from other benign entities. Here's another mass concerning for lung cancer. This was also persistent on a number of follow-up scans, even grew a little bit. A PET was performed and it was very avid, again suspicious. We don't see any distant metastatic disease on this PET. A biopsy was then performed for confirmation, and here we go again, another positive AFB on the biopsy. So this is tuberculosis, so granulomatous infection absolutely can be a mimic of lung cancer and is a reason why we do many biopsies trying to establish the diagnosis of lung cancer. Fungal infection is another mimic, as I referred to earlier. Here's Aspergillus, Cryptococcus, Cocci. Just like I said in the pulmonary infections lecture, we know what these are because they were sampled. So persistent nodules and masses, suspicious for cancer, but ultimately end up being infection, should be on your differential and ruled out by tissue sampling. Metastases can also mimic primary lung cancer, so a history of some other cancer is helpful. Some primary cancers are particularly prone to look like primary lung, and we've noticed that with pancreatic adenocarcinoma. Perhaps it has to do with the similar histology. This is a spiculated mass, very suggestive of a primary lung cancer, but it turns out to be metastatic pancreatic adenocarcinoma rather than primary adenocarcinoma of the lung. Other metastatic tumors can also mimic lung cancer. Hematologic malignancy or pulmonary lymphoma can cause many masses in the lung that are suspicious for malignancy. Here's a patient with a kidney transplant and post-transplant lymphoproliferative disorder or lymphoproliferative disease with a pulmonary nodule. So tissue sampling and appropriate history will help us distinguish those.